Welcome to the next episode of ASAP Conversations. I'm Suchitra Dalvi, coordinator of the Asia Safe Abortion Partnership. And we're very pleased to have with us here today Dr. Subatra Jayaraj from Malaysia. Subha, would you like to introduce yourself a little bit, please?
Hi everyone, my name is Dr. Subatra Jayaraj. I'm a primary care physician and I run a women-friendly clinic in Kuala Lumpur, Malaysia, providing the complete range of sexual and reproductive health services, including termination of pregnancies.
Oh, that's wonderful to know. I'm sure you must be, I know you're extremely busy right now and you've taken time out of your clinical schedule to speak to us, and we're really grateful for that. So could you just give us a little bit of a background about the abortion law in Malaysia? Like, is it criminalized? Is it legalized? Whether facilities are available for free in public sector, private sector? Just a bit of a background on that, please.
Okay, in Malaysia, the law is reasonably progressive compared to the rest of the world. Termination of pregnancies is allowed if, by good faith, a doctor decides that it is to be done to, number one, save the mother's life, number two, for the mental or physical health of the patient. So, in a sense, generally, accessible, and most procedures are actually done under the guise of for the mental health of the patient. Although we have a termination of pregnancy guidelines by the Ministry of Health Malaysia, a majority of terminations are actually done in the private sector. The public sector hospitals only sort of restrict their procedures to saving the mother's life, but majority of the procedures, then clients have to go to the private sector. Generally in Malaysia, as with the rest of the world, 90% of pregnancies 90% of terminations occur in the first trimester. We do get our fair share of second trimester requests. And this has actually increased in view of the COVID-19 situation. We've had a few movement control orders phases since 17th of March 2020 when the COVID outbreak started in Malaysia. So the restriction of movement has changed a little bit of access. But generally, majority of clients, a majority of procedures are still accessible.
Right. So just to talk about what happened pre-COVID in terms of access to abortions, you're saying it was still accessible. So is it easily accessible for women in the private sector in terms of costs or, geographical access? Is there a lot of stigma around it? Are abortion clinics standalone or are they part of women's health facilities?
Unfortunately, even if the termination of procedure is actually legal and available in Malaysia, however, accessibility becomes questionable when it's a very stigmatized procedure. And also there's a lot of different understandings by the medical health professionals themselves. I'm the Honorary Secretary of the Reproductive Rights Advocacy Alliance and also part of the ASAP Steering Committee. And RAM, we've done a few research amongst ONG professionals, and majority of them do not actually know that the procedure is legal in Malaysia. So what happens is that the clients are pushed from one clinic to another, and it depends on if the doctors are actually willing to provide, number one, or trained to provide the procedure. And then becomes the issue of cost as well. So because the issue and the procedure is very stigmatized, a lot of clients are the range of exploited financially. So the range of costs for termination procedures range from about 700 ringgit, which is about $200 US, to about 5,000 and 6,000 ringgit. So it depends. Majority of private hospitals charge a lot. If you add anesthesia and all for a very simple case, it will become a couple of thousand ringgit. So cost is also very prohibitive. Another prohibitive factor is where the clinics are. My clinic is situated in the Klang Valley in Kuala Lumpur, the capital, near the capital. traveling hours, 9 hours to my clinic. And there's also not very many doctors who actually openly provide services. So that's also a challenge for us.
Right, right. So I'm glad you spoke about RAM, because I did want to ask you about the scope of work of RAM, and also to say that we're really grateful to have had collaborations with RAM through all these years. In fact, as you know, one of our founding members was Dr. S.P. Chung, who is very active in RAM as well, and you are now on our steering committee. So could you tell us a little bit more about RAM, why it was founded, what is the work that you've been doing, and are you addressing the issues that you just mentioned, the stigma with medical providers still have, or the fact that women need to, so the way you're describing the private sector services, it's almost like an underground service in a sense. Although the law is reasonably liberal, there's a lot of stigma from both sides, and everybody has to kind of hide and find a lot of money to be able to sort of pay for their sins in that sense, and get these very
Yes,
expensive procedures,
exactly.
which should actually be available for free in the public sector, because your law is fairly liberal.
Which is also why RAM was formed 10 years ago, because despite the law, the procedures being legal, there's a huge kind of barriers around, and RAM was formed as an advocacy organization, formed by individuals, organizations, and also healthcare providers. So we also have legal organizations and women's rights organizations to provide a lived reality perspective, and all come together and advocate for reproductive rights in general, and which includes access to termination of pregnancy and contraception. Unfortunately, yes, it is kind of a hidden procedure or a hidden service. And what RAM does is also we run a hotline to provide clients where to access the service. So that's another thing. Nobody knows which clinics to go to,
Right.
and then just jumping from one clinic, being referred to one clinic to another, also delays the procedure. So RAM runs a hotline to actually kind of facilitate which clinics provide services depending on which location, geographical locations they are. So they don't have to travel 8-9 hours and come and see us in
Yeah.
here.
That sounds like an
RAM
excellent
also
service.
provides options for medical abortion, which is not accessible right now in Malaysia. So what we do, we give them the complete range of options, which is surgical option, which is available via service providers in Malaysia, or a medical abortion, which is currently not allowed in Malaysia because the government has restricted the medication and it's not registered. But we do recommend options such as women on web, or accessible, reliable, safe services that they can access.
So what has been the government's justification for not registering mifepristone, given that the law sort of allows abortion procedures?
As usual, there's a lot of justification, which is actually for us not justification. The latest reasons they said was that we do not need that because there are alternatives available. So the alternatives they're talking about is actually like medication like Cervidim, which is 100 times more expensive than like a tablet of Cytotec actually. So that's what is used in the public hospitals. But we don't see why you should actually insert a medication per vaginally. It is not women friendly. It's cost prohibitive, and it also is it's a different safety profile compared to Cytotec. We all know why countries.
Combination of mifepristone and misoprostol is so much more effective, right? Rather than just misoprostol.
Exactly. So evidence has shown that it's so much more cost effective, so much more safe, so much more accessible, if used in the correct dose with proper guidance. But there's a lot of social, political, religious aspects to reproductive rights, and we actually had a document come out which really showed how cost effective and how there was a benefit and how safe it was. And then unfortunately the conclusion of the document was totally the opposite, to say that we do not need it at this point of time because we have an alternative. Honestly, the alternative is really bad because it prevents access, and as we know, preventing access to termination of pregnancies only encourages unsafe abortion, which we see right now. So when unsafe abortion in Malaysia generally is because a lot of black market providers provide medication online not guided and not the correct regime.
Right.
So we see a lot of that as well.
Right. So it's a very challenging environment in which you're working. I just wanted to ask you in terms of the whole spectrum, because RAM talks about reproductive rights, and I know that unsafe abortion is not the only pathway that women choose when they don't access safe abortion. I know that baby dumping has been a very big issue in Malaysia for a while, and so there's a whole spectrum of issues, right, with sexuality education. And correct me if I'm wrong, but I think it's not legal to provide contraception to unmarried young people. You also have an issue of child marriages, the way we do in India and in many parts of the Asia. So how do you see, what role does RAM see in this whole gamut of issues, within which abortion also, of course, the stigma of sexuality and abortion is something which is very strongly seen and suffered by the women who are going through it.
Definitely reproductive rights. I mean, it includes the right to access services and right to information. And a huge part of it is actually addressing the right to information and stigma as well. So baby dumping, unfortunately, is very highlighted in Malaysia. We get one known case of baby dumping case every 3 days, according to statistics for the last 5 years. So that's quite a lot. There's like 100 babies found per year. So there's been many kind of things that they've been doing, such as baby hatches and all, but it doesn't really address the issue. Why clients are actually resorting to baby dumping is because they have nowhere to go. They have a whole huge stigma behind a pregnancy that is unwanted. They don't know where to go in early on. They don't have the access to information. That termination is an option that is safe and available in Malaysia. So what happens is that they find out really late. Also, sexuality education is not very covered in Malaysia. We have really bad comprehensive sexuality education, and many of my clients do not know if you're sexually active and you miss your period, which means you're pregnant until proven otherwise. So this is like just a failure of the system. Why don't women who miss their periods know that there is a risk of pregnancy? It's just basic information that every individual should know. Unfortunately, what happens is they come late, and if they come later than the second trimester, then there's very little we can do. So also going into public hospitals is a huge stigma if you're Muslim. So we are a Muslim majority country, and there's different laws that govern Muslims. It's illegal to give contraception. That's not true. There's neither it's legal or illegal to give. Married people can access medication as everybody else, but it depends on where you go. Right. So it's whether if you go to a hospital or if it depends on the health provider whether they want to judge and they want to provide the service. So there's no law as any other medication, but it's unfortunate that people include their judgment into providing medical services.
So I think Malaysia, like any other country in our part of the world, is suffering from these multiple intersectional, structural inequities. In terms of race, in terms of patriarchy, in terms of sexism, gender discrimination. So what are the lessons that we are learning through the COVID pandemic and the responses to it that can help us advocate for what we are liking to call now the new normal? Because I remember some time back there was an article about, I think, the Ministry of Women and Family Welfare from Malaysia, which gave some very bizarre advice for women on how to behave, to keep their husbands happy during the lockdown. And it kind of, I think it just brought to mind the fact that there's so much stereotyping and so much of a pressure on women as well as men to follow certain roles. Like the men are supposed to be these helpless, almost infantilized creatures, even as adults. And the women are supposed to kind of be wife and mother and everything at the same time. So how do you think, being forced to stay at home, are men helping out with domestic work more? Are doctors recognizing, or even the health system recognizing the gaps that people have had for access? And do you think things might improve afterwards?
Yeah, that's very unfortunate what the Minister of Women and Community Development actually said. And then they came up with in international use, saying that women should stay at home and take care of their husbands and all sorts, which is not really addressing the structural issues of domestic violence. And also what's happened especially in this movement control order, that we've restricted movement and forced people to stay at home. So with forcing people to stay at home or, at prolonged points of time, without any protection and without any options and information and access, and women are not able to choose for themselves what they want. Yeah, so rather than actually coming up with their own stereotypical judgment, what we always advocate for is following the evidence, and the evidence is quite clear that domestic violence has increased during this MCO period. People cannot access contraception. So what we should do is to facilitate these kind of access. What we've learned is that I think the world over as well, that medical abortion is a very good alternative. If you cannot access a service provider personally to come face to face, if in the early stages of pregnancy, medical termination is very safe, and we should actually facilitate it. Unfortunately, we're falling very, very much behind. So this is one of the lessons we've learned. But in Malaysia, what we have realized is also that it also depends on, depending on an international source, depends on the whole supply chain. And Women on Web has actually said that the stores were depleted for a while, coming to Malaysia, and there was a gap in the supply chain for a while, but I think it's back to normal. But why can't we have medical abortion pills given online, same as how many hospitals have started giving medications via the post? So we can do it with other medications during the movement control order, but we cannot do it with certain other procedures and medication, and this just bias. The other challenge is also a lot of university students have been forced to go back home last minute. And 30 to 40% of our clients are young in university and all. So if they're back home and under a household which is very controlled and limited, it also will show that they have no access to come for services. And then we've seen on access.
Right. I think, yes, we are all going through a phase of very difficult transitions. Some people are more vulnerable than the others because of their already existing, inequalities. Like, for example, in India, we've been discussing with our partners who work with the queer community or, with the sex workers collectives. And as you said, quite rightly, young people who've got used to all the freedom they've had in the universities are suddenly kind of under household surveillance. So do you have any sort of, last messages for us as a provider? Because I know you are in the middle of your clinic work. You've already seen some clients in the morning, and you still have to continue. So is there anything you're seeing from what, any messages of resilience or, any positive messages that are emerging from these women who are finding their way to you during this pandemic?
I think it's very important for them to know that services are still available. So although I get a lot of requests on my care line or our appointment line, is they're not coming to the clinic. So I think there's a gap between them actually able to travel and then them actually coming here. But just knowing that services are available is a huge advantage. The next day itself, I saw 2 clients who had to stop their contraceptive pills, but couldn't get them during these past 2 months and then ended up pregnant. So also to put it out there that contraceptive medical services and pharmacies are still open, and they should be able to go and get access is there. So to push out information that services are available is very important, and there is help available. And we keep pushing our hotline as well to see if anybody is there, and we've seen a little bit of a spike in the hotline. Advocacy wise, we have to push really harder. Right now, a lot of medical, the Ministry of Health has a budget that it has been so much diverted to infectious disease, specifically on COVID, maintaining hospitals. So we know that the focus is not going to be on reproductive health. Maybe, yes, the Ministry of Health has recognized that, yes, there's going to be a baby boom in 9 months, but that just shows you there's recognition of the issue.
Yeah.
But they do not think, they've not said on how many these pregnancies will be unintended. We know that a lot of people have been suddenly out of a job. They've not been paid. There's a lot more socioeconomic challenges. So people will have differences in whether they will want to continue the pregnancy or not. And I feel like we need to continue providing options to women so that they know that these options are available. That's what we need to do.
Thank you so much for that positive message, and thank you very much for the work you do with RAM, as well as, in your personal capacity as a safe abortion provider. You're continuing to provide the service through the pandemic, and we just wish you to stay safe and take care. And thank you very much for your continued association with ASAP. Thank you for joining us, and we look forward to catching up post-pandemic. Thank you.
We say service providers are the frontliners, and we need to keep going. But also behind the scenes, our project officer and our hotline counselors, they've been really working really well as well. So
right,
thank you
yes,
very
absolutely.
much.
We thank the
So
entire clinical team. Yes, we thank the entire clinical team, all the healthcare providers who are, sort of defending the front lines and making sure people still have access to the services they need. So thank you all very much, and thank you for joining us today for this conversation. Thank you, Dr. Subha.